Learning Plan 2, Part 6, the final part, obtaining the good death. That sounds kind of like a contradiction of terms. But a good death is when everybody is satisfied with the plan of care, when the decisions that have been made with information and guidance, and the person is provided comfort care, comfort measures. Unfortunately, this level of care happens very rarely. Many times, diagnosis of dying occurs only hours or days before the death actually happens. So there's really very little time to provide quality end-of-life care. When a person has an expectedly terminal disease, but an unknown, I mean, they know it's going to be terminal, but it could be months away, that gives hospice a chance to come in there and start providing that good death background for everybody. Begin the grieving process early, because it's less unknown. Now there is a trajectory. There we go, of dying. So if you start seeing increased hospitalizations, marked physical or functional decline, new incontinence, decreased food or fluid intake, especially eating less than 75% consistently, progressive weight loss. Weight loss of more than 10% is a big deal. That's a major problem, major sign. Increasing time sleeping, behavioral, cognitive changes, statements about death, or saying goodbye to people, calling people up to say goodbye, writing goodbye letters. Those are all signs that death is coming. It's hard to predict. You can see some physical signs. You can see a lower respiratory, things like lower respiratory infection and pneumonia in the last 90 days is a predictor. CHF, chronic renal failure, cancers, especially when you combine with advanced age and bed rest. Those are predictors, but it's not guaranteed. It's just you should start thinking of that. If you work at a nursing home, you need to document all of these changes. Very important. So is palliative care more acceptable than hospice care? You know, I understand what palliative means. Most people may not. Hospice sounds a lot like hospital. So how about allowing natural death versus DNR? Allow natural death. Doesn't that sound nice? So residents and families need to understand what options are available between full code and doing nothing. Because there is that mid-ground. Mid-ground isn't necessarily good ground, but there is mid-ground. So do we hospitalize only if needed for comfort measures? Do we do cardiac monitoring or not? Do we give oral medications or IV medications, but no intubation? Successful treatment of multiple symptoms is challenging. They reviewed 1,000 dying patients. 50% experienced 11 or more symptoms, with the number of symptoms ranging between 1 and 27. Pain, fatigue, weakness, anorexia, lack of energy, dry mouth, constipation, those are the most prevalent symptoms. And back in 2002, Wisconsin nursing homes got an overall D in pain control. Pain is a big deal. Pain is a huge deal. If you've ever had pain, you know. Pain control is it's not necessarily curative, but if there's no pain control, curing is difficult because the focus is on pain. So when we're in clinicals with me, we're going to make pain control a priority. So what about dyspnea? Alleviating dyspnea, difficulty breathing, and we overdose them. Opioids, morphine in particular, is a wonderful pain reliever and is the pain reliever of choice, especially for long-term cancer pain. Opioids really work. You give morphine, could be orally, could be IV. The first thing it does is it relieves symptoms. It takes away the pain. Before it even causes sedation, it relieves pain. And if you relieve the pain, you've given enough medicine. Now, if you give a little too much medicine, it's going to cause them to be sedated, but not have respiratory depression yet. It's just going to be sedated. If you give more than that, that's when you get into the realm of respiratory depression. It's not sudden, it's not mysterious, and it is totally controllable and predictable. Some patients may need to get to sedation before they actually obtain relief. That's okay. But you stop then. If a person goes to sleep, you stop giving them medicine. They wake up, you can give them more medicine. That's common nursing sense. And that's why we aren't really concerned with overdosing for pain control, because it follows a predictable chain of events. Pharmacologic management. Morphine is the treatment for those with pain. 2.5 to 5 milligrams orally every 4 hours, and a double dose at bedtime. But that's very small, because you can go into the hundreds of milligrams orally for long-term chronic pain of cancer. When you give morphine, it also works in the lung tissues, and it helps decreases the symptoms of dyspnea as well as controlling pain. So that's why morphine is the pain medication of choice. Might give corticosteroids to help reduce inflammation, reducing pain, and making breathing easier. Again, we're not going to cure anybody with corticosteroids, but we're going to reduce symptoms. Chlorpromazine also reduces dyspnea without affecting ventilation or causing sedation. We can give scopolamine, which reduces secretions and sedates the patient. We'll give transdermal patches, usually right behind the ear. Dry the secretions to reduce the choking risks. Non-pharmacological, of course, we can give oxygen. We can help air movement. We can put a fan blowing on their face. That sometimes just having air blowing on the person's face will help them breathe. We will put them in positions in bed that improve ventilation. And we're going to avoid talking, avoid all activity. The final days and hours before death, a number of signs and symptoms follow a predictable pattern. The person stops eating and drinking. Developing oliguria with minimal urine output, difficulty breathing. They get very cool. Their symptoms, their extremities start to develop cyanosis. They have decreased level of consciousness. They could have become disoriented. They could talk to people and talk to people that you don't see. I've seen that a couple times. So these are all signs that death is imminent. Last 48 hours, we're going to be watching very carefully. And of course, you never know when the last 48 hours start. But when you start seeing reduced level of consciousness and they're not taking fluids and they have very low urine output, you can assume that if you're not in the last 48 hours, you're darn close to it. When you start seeing the purple of the arms and legs, bubbling sounds, the death rattle, it's real. You can assume death is rapidly approaching. What happens if you're in a situation where you think there's been a wrong decision? Well, every facility should have an ethics committee, and you should go to the ethics committee. You can talk about what options are available. Talk about who should make decisions and on what basis. And maybe talk to a person about your own opinions and feelings about this. It may not be an ethical dilemma in the big picture. It may be an ethical dilemma within you. That's not wrong. That's not wrong at all. Remember, I said if we understand ourselves, we have a better chance of understanding why other people may choose something else. But that's the end of Learning Plan 2.